The next speaker is Dr. Steve Hoff. He'll be speaking about minimally invasive alternative lesion sets.
Thank you, Tom. I appreciate the opportunity to come speak with you today, and I'm the flip side of the coin that Ralph has just described to you, and we'll try to talk a little bit about some of the appropriate ways we think we may be able to start to achieve some of the concepts that Ralph and Dr. Cox have taught us all about for years. So we'll talk about at least one, I think, perhaps the most promising minimally invasive alternative for AF ablation in non-paroxysmal lone AFib with an epicardial and endocardial hybrid lesion set. We'll talk a little bit about the rationale for that and how that kind of fits into this maze paradigm that Dr. Damiano has told us about, who may be appropriate for that, how we can safely and effectively achieve that, and some of the results that we're starting to now see in the literature. So when we think about an integrated approach to complex symptomatic lone atrial fibrillation, we're going to concentrate today on non-paroxysmal AFib and in particular talk about how a hybrid procedure may begin to approach what Dr. Damiano has told us, I believe, is the gold standard for this, and that would be a surgical approach. So what's the rationale for the thoughts of using a staged surgical and catheter-based hybrid procedure? Well, as Dr. Damiano has told us, that we're limited by our technology. A complete maze lesion set really cannot be performed off-pump thoracoscopically. Similarly, our electrophysiology colleagues don't have the technology to perform a complete maze lesion set with a catheter. Although they are very good at localizing and closing the gaps of failed surgical lesions and are excellent in completing conduction block in narrow confined areas of the atrium. As Dr. Damiano mentioned, we believe that even now biatrial macro-reentrant circuits are what maintain complex AFib because the Cox-Maze 3 lesion set works. Surgeons' tools in general are better at debulking long lines of ablation than our EP colleagues, although their tools and experience are better at testing lines of ablation perhaps than some of the tools that we have. So the concept then would be to use the best of both of these technologies to interrupt all those macro-reentrant circuits, reduce invasiveness, hopefully without sacrificing results and making the combined procedure safer and perhaps more patient-friendly. In that way, we prefer to work with rather than compete against our electrophysiology colleagues for the benefit of patients. And we've seen this approach work several times. We heard all this yesterday in the TAVR world. We've seen it work with hybrid revascularization, that this team approach tends to be extremely effective and well thought of. So if these are the documented left atrial macro-entrant circuits that perpetuate non-paroxysmal atrial fibrillation, then if we can create left-sided ablations with bilateral pulmonary vein isolation and the superior and inferior connecting lines that Dr. Damiano just told us about, that should relieve most of the macro-reentrant circuits thought to perpetuate non-paroxysmal atrial fibrillation. If we take this line of ablation up to the left atrial appendage and take the left atrial appendage electrophysiologically, we should ablate the majority or the majority of these left atrial reentrant circuits. We'll talk about that in just a minute. Then what we do with this procedure is we leave radiopaque clips at the corners of this box and on the coronary sinus to help our EP colleagues. And that's the completed initial thoracoscopic procedure that we'll talk a little bit about in just a minute diagrammatically and then go through in the lab today. Then with follow-up catheter ablation, oftentimes the leftover circuits are these basal left atrial circuits that Dr. Damiano was just telling you about that create this just horrible, awful left atrial flutter. Now with a roadmap, both an electroanatomic roadmap and our radiopaque clips, it gives our EP colleagues the opportunity to ablate across those into the sinus and complete what we hope would be a left-sided maze lesion set. So who may be an appropriate candidate for this? Well, it's very similar to the patient population that Ralph was telling us about. We're talking about patients with lone atrial fibrillation that are highly symptomatic, medically refractory, often have failed one or more catheter procedures. and perhaps show anatomic characteristics that may be associated with poor results, either medically treated or with catheter base, such as significant AF burden specificity and large left atrium. So the logistics of this procedure are, this we believe can be formed either as a same-day hybrid or a staged hybrid, and we can talk in the discussion period about some of the data that we've, for better or worse, generated that would suggest that perhaps a staged procedure is even better. These lesions are performed endoscopically on a beating heart off pump using radiofrequency energy. We begin with creating right-sided lines, then move to the left side, ligate the appendage, and as Ralph mentioned, we believe firmly that a good pattern of epicardial and endocardial testing is extremely important, and then our EP colleagues come in and do the same thing endocardially. So the thoracoscopic lesion set then, again with important pre- and post-operative testing, includes bilateral pulmonary vein isolation, superior and inferior connecting lines aligned to the left atrial appendage. We have variably used the coronary sinus line. In the past, it is possible to ablate across the coronary sinus with this technique, though the problem often then becomes we'll actually create more problems than we cure. And so it's actually become more standard for us to leave coronary sinus caval lines, or coronary sinus and to our EP colleagues. There's been some data to suggest that things like ganglionic plexi mapping and even to a lesser extent right-sided lines may not cost us the efficacy that that we might have initially thought, and that while it's possible to create those lines, we're actually becoming less and less aggressive about doing those lines and haven't seen much of a drop-off in efficacy. And then our EP colleagues come in again, map the posterior left atrium, test and augment our surgical lines. As Dr. Damiano said, with our less than perfect technology, it's not an uncommon thing for that to be necessary. Cafe map, if you believe in that sort of thing, create a mitral line, and then a CTI line for right-sided flutter. So this is a Cardo map looking at a post-ablation thoracoscopic ablation patient. For those that don't read these on a daily basis, and for us simple surgeons, red is dead. And what this basically shows is good posterior left atrial wall ablation aside from a gap in the superior connecting line. And this is the sort of thing that with very good success rate, our EPs these days can now identify these gaps and close them with leading to much better efficacy, I think. So what are the keys in trying to accomplish this efficaciously and safely? We'll kind of go through this diagrammatically, and then we'll go through it in much greater extent in the lab. Patient positioning is important to allow us scope position, and this can be achieved both by elevating the patient's chest on sheets or with bilateral inflatable Roho mattresses. So the patient is positioned something like this if they're up on sheets, or this is a patient of ours that's up on these inflatable Roho mattresses. That allows us to place 3 working ports on each side of the chest. There are some surgeons who prefer a 4th retraction site. We've never really found that necessary. It's basically 2 working ports and a scope port. And as with most thoracoscopic procedures, there's an advantage to having a wider array for more working room, but a narrower array sometimes will give you a more direct view of the chest. Our port access looks something like this on the left side and looks like this in the operating room. There are a couple of different options from scope standpoint. I have colleagues that prefer 5mm scopes for this. I tend to find them a bit fragile and have modified 1 or 2 in my day with retraction and that sort of thing. So I typically go with 10mm scopes. The incisions are perhaps a little less cosmetic and attractive, but I think the 10mm scope is a little more forgiving. So we start with the 5mm port in the scope site just to allow us to actually place the rest of the ports under direct visualization and to have an idea of what the chest anatomy looks like, so the scope's ports aren't too high or too low and allow us an appropriate means of doing that. And then we changed to a 10 millimeter 30-degree scope where we make the rest of the incisions and then upsize our initial scope port to 3 10 millimeter ports. And we did the same thing on both sides ultimately. When you're opening the pericardium, it's really all about the phrenic nerve. We tend to dissect some of the epicardial fat away, which allows the phrenic to fall away inferiorly in some places. We make this incision with scissors. Often others have used a bovie or harmonic scalpel. Generally, the little blood vessels in the pericardium will stop even anticoagulated, so we really don't worry too terribly much about that for fear that bovieing in this area may impact the phrenic nerve. It's a bad thing to have phrenic nerve palsy in one of these patients. They're often at least moderately symptomatic. It's really, really bad to create bilateral phrenic nerve injuries, and that's just is a never phenomenon. That's just the one thing you have to keep in mind in this procedure, I believe. So we typically open the pericardium about 3 centimeters anterior to the phrenic nerve on the right side. Obviously, too close to the phrenic, you risk damaging it. Too far away, and it's actually sometimes difficult to see over that pericardiotomy into the posterior left atrium. And I've seen surgeons get in trouble actually with poor visualization, trying to spare the phrenic and be too far away from it when they open the pericardium to be able to really see where they're dissecting. So the pericardiotomy incision again goes down to the IVC on the right side. On the left side, it's more it's posterior to the phrenic nerve and a much more posterior incision that allows you to open way down toward the mass of the left ventricle to be able to dissect. I tend to close the left-sided pericardial incision. Some surgeons close both. I've never seen myself herniation through this pericardial incision through the right side. I didn't think it was anatomically possible. One of my buddies said it actually happened to him. So that's the only time I've ever heard of it in the world, but that's the routine that we have. From a retraction standpoint, we place retraction sutures in the pericardium posteriorly on the right and then bring them out to another chest incision with the Carter-Thompson suture grasper that Ralph showed you in the movie very nicely. I placed 4 on the left. Again, we'll go through all this in the lab to really provide what I think is excellent exposure. A little bit more retraction on the left side to allow complete visualization of left atrial appendage so that you can safely manage it completely. Dissection is done not dissimilar to what you saw in Ralph's video with the oblique and transverse sinus. We use a combination of a long irrigation endoscopic irrigator and endokitteners to dissect both the oblique and transverse sinuses completely to let you get around the pulmonary artery or pulmonary veins, just like Dr. Damiano was showing us. This also helps us dissect in the area of the roof of the left atrium and help to skeletonize some of that and remove some of that left atrial fat along the dome of the left atrium, which is detrimental to creating that roof line as far as using these unidirectional bipolar devices, as we've seen from some of Ralph's lab data. So this is just diagrammatically what we're talking about with tissue dissection for the oblique sinus and the transverse sinus. And then from a retraction standpoint, we like the endokittener for us is sort of our go-to workhorse retractor. It's really safe to retract all structures, and we found no problems with that anatomically. We also use an endoscopic fan retractor to help in creating several areas of dissection. This can help retract really all the important structures as you're dividing ligament and Marshall. It allows us to elevate the ventricle to inspect the completeness of and direction of posterior left atrial wall lesions, as well as to protect the esophagus from heating during the performance of this procedure. So again, we tend to use the lighted dissector endoscopically to encircle the pulmonary veins. We place the bipolar clamp, as Dr. Damiano showed you in the video, across the left atrial cuff. This is using this unidirectional bipolar device epicardially, delivering RF to both begin the superior and inferior connecting lines. We'll then move to the left side, create the same ports and access that we talked about. Use the lighted dissector to encircle the left-sided veins. clamp the cuff of the left atrium, complete our superior and inferior connecting lines with the unidirectional device, and then create a line to the base of the left atrial appendage, and then ligate it. So again, we believe that managing left atrial appendage for this procedure is critically important, both from a stroke reduction standpoint and from an electrophysiologic standpoint. This kind of completes what could be considered a maze lesion set. I think it's also one of the big advantages for some of the other epicardial hybrid type procedures that are out there, and we can talk about those a little bit more if you like at the discussion section or in the lab. The device that we use is the AtriClip device for a couple of different reasons. I believe that with its linear closure as opposed to the circular devices that have been on the market before, the closure forces are in the same orientations of left atrial appendage anatomy, and it allows a much more complete ligation of the appendage. With this particular device, which is circumferential, the likelihood of getting a recurrent gap is essentially zero, and the only thing you have to be careful about is making sure that you can get this all the way down to the base left atrial appendage, which is again why when I said making pericardial incisions and putting retraction sutures in is so important, to be able to see the entire left atrial appendage and understand its anatomic variability. And the nice thing about this clip is not only does it address the mechanical, but also the electrophysiologic aspects of left atrial appendage ligation. So this is a video of how we do this. The device is placed to begin with across the base left atrial appendage. This is a little padded grasper that Dr. Edgerton turned me on to, which I think is very nice and very gentle, and basically allows us to pull the entirety of the left atrial appendage up as we apply this right on the base, and we get a nice flush ligation. So this then becomes the final thoracoscopic hybrid lesion set with bilateral pulmonary vein isolation, those superior and inferior connecting lines. You can see the little red tennis ball on the superior line. That would simulate a gap in our surgical line that our EP colleagues would close for us. This includes a line to the left atrial appendage with a clip, a mitral isthmus line performed by our colleagues, a CTI line, and right-sided lines, whether we prefer that or not. And obviously it allows us the opportunity to test and ablate for ganglionic plexi if we believe in that, ligate the ligament of Marshall, and cafes if we like as well. So I don't know if it was my surprise, but my delight. In one meeting that we were at a couple of years ago, Dr. Cox actually admitted he believes that this is, or at least approaches, a maze lesion set. So how about results? Well, these are some studies that were published early on, I think, with this technology, and a lot of these studies are small. They have relatively limited follow-up, certainly early on in this technology, but had reasonable AFib-free survival that they described. More recently, several other studies have been published. These studies are predominantly in non-paroxysmal patients, a little bit larger studies, a little bit longer follow-up, some with continuous monitoring. And again, the drug-free, AFib-free survival tends to be really very good in experienced hands. And so I think that these results, while probably still a little bit preliminary, are encouraging, I think, for the use of this type of technology. So as we put this together, this is a little bit of a busy slide, but as we kind of put this together in this integrated approach for complex symptomatic AFib, our approach has tended to be for those patients with persistent and long-standing persistent atrial fibrillation that are candidates for a thoracoscopic hybrid procedure. That's been our treatment of choice. Now, if they're not, then obviously there are several other options, and there are many indications where we've gone to a minimally invasive endocardial cryo Cox-Maze 4, as Dr. Damiano described to you. We've used in highly selected circumstances the pericardioscopic hybrid ablation, the in-contact type procedure. To follow up on the question that was asked of Ralph earlier, I've tended to use this really only on patients that have failed catheter ablation and really still have only paroxysmal disease. I think that this lesion set's really only for the posterior left atrial wall. It has to be done as a hybrid procedure, can't be done as a stage procedure, and it's probably its only potential utility, and then really only in patients who aren't candidates for perhaps a more rigorous lesion set. We've tended to use it in patients with either poor pulmonary function or cardiac function. And certainly there are plenty of patients who get treated with rate-limiting drugs and anticoagulation or further catheter ablation. So in summary, then, I think that while this hybrid approach isn't the Cox-Maze 8 or 9, I believe it is based on all the principles that the Cox-Maze 3 and 4 stand for and are the gold standard for, and that current data would suggest are necessary to treat complex refractory AFib. I think that the data is now beginning to show that it's a safe and effective way to begin to have potentially a minimally invasive alternative for this complex AFib in multiple single center studies. That it tends to reduce patient impact and may be more appealing for some patients and referring physicians, and certainly helps build the relationships and referrals that we've seen before in other hybrid type procedures like TAVR. So I'll end with this. This was published by Dr. Cox in 2013, which I thought was kind of interesting when I ran across it. So at that point, Dr. Cox said that the ideal minimally invasive ablation procedure would be epicardial beating heart with an energy source that allows us to ablate transmurally, which we really probably don't have yet, that would allow us to treat all forms of atrial fibrillation and flutter, avoid coronary bypass, be endoscopic, take an hour, and in the absence of complications, be ready for discharge the next day. So I don't think we've really quite accomplished that yet, but I'm hopeful that this is a move in that direction. So with that, I'll thank the two people that taught me how to do this, and next, maybe Ralph, have taught me the most about AFib, Dr. Edgerton and Dr. Cox. So thank you.